My name is Dickran Kazandjian, and I am a clinical investigator in the myeloma program, the Center for Cancer Research, National Cancer Institute, located in Bethesda, Maryland. I'm here today to discuss some of our results for our clinical trial in high-risk smoldering myeloma using the regimen KRd with R maintenance, which is carfilzomib, lenalidomide, and dexamethasone, followed by lenalidomide maintenance therapy. In this study, we enrolled 54 patients who underwent 8 cycles of induction therapy with KRd, followed by 2 years of maintenance therapy. Importantly, the primary endpoint of this study was depth of response, specifically rate of minimal residual disease negativity at 10 to the minus 5 sensitivity. And at this time point, approximately 6 years of follow-up duration, we found that 70% of patients did reach an MRD negative complete response. Even more impressive was that these deep responses were sustained. For example, the median duration of MRD negativity for those patients who reached it was 5.5 years. And second most important, and one may argue the most important, especially for patients, was the progression-free survival rate, progression to overt multiple myeloma with end organ damage. And we found that at the 8-year milestone time point, approximately 9% of patients developed overt myeloma, and 91% were free from developing end organ damage. This is fairly impressive compared to the natural history of high-risk smoldering multiple myeloma, which states that at the median, at 5 years, 80% of patients will develop overt myeloma, or at 2 years, 50% will develop overt myeloma. And as I mentioned, in our study, at the 8-year milestone, 9% only develop multiple myeloma. Now, the next logical question for the audience would be, should this be the new standard of care? As much as we were fairly impressed with these results, the answer is no. This data in itself is not enough to make KRd with R maintenance standard of care in the treatment of high-risk smoldering multiple myeloma. I would furthermore argue that we do not have any standard of care regimens to treat high-risk smoldering myeloma. However, it is of utmost importance that patients who have high-risk multiple myeloma, smoldering multiple myeloma, be enrolled on clinical trials to evaluate the different regimens. And lastly, I would say, in order for KRd with R maintenance to make it, so to speak, in prime time treatment for high-risk smoldering multiple myeloma, a randomized study would need to be done with fairly long follow-up time to capture the true rate of delaying progression to overt myeloma, and even more so, potentially to evaluate the rate of functional cures. Thank you.